Hi, let's discuss about um, some basics of pharmacokinetics, pharmacodynamics, as well as some basic concept of general pharmacology. Okay, so today, 21st 8, right? So let's start up with the pharmacokinetics. Now, this is what is important, that pharmacokinetics has ADME. Okay, it's also known as ADME studies, that is the absorption, distribution, metabolism and elimination. So this is what the body does to the drugs. Okay, so body does to the drug. Okay, and another concept is what drug does to the body, and that is pharmacodynamics, and what the body does to the drug is pharmacokinetics. Okay, so we are going to start A, D, M and E. A for absorption, distribution, metabolism and elimination. Okay, now in absorption, basically what we are going to see is bioavailability. In distribution, we'll see volume of distribution and apparent volume of distribution, right? In metabolism and elimination, we'll see clearance. Okay, so we'll learn about elimination, excretion. Okay, and there is something important, Hoffman elimination, right? There are many things we have to discuss. So first we'll discuss the absorption. Barrier across to reach the systemic circulations, that is the veins, that is the absorption, right? So absorption has to cross cells, so there are barriers present. Okay, basically the cells have lipid more than protein. Okay, so lipid content is more than protein, right? In the cell membrane, lipid is more than protein, right? So it has called some to have to cross some barriers, right? The cell membrane. Now these are like, what are the process? So this is the passive absorption, that is diffusion. In the diffusion is this the most common mode of transport. Okay, so lipophilic and non-ionic drugs will pass and no ATP is required, and it is along the concentration gradient. Similarly, filtration is along the concentration gradient. It has not requirement of any ATP, and ionic and water soluble substance pass through it, and there are aqueous channels or pores present, to pass, right, like this. Now carrier mediated, it may be two types: facilitated diffusion and active transport. Now the facilitated diffusion need not use of ATP, and it's very important because it's also a diffusion and it is facilitated, but it is along the concentration gradient, and some facility is required, that is some channels are required, SGLT and 5FPU. Okay, so these are the ways how diffusion occurs. Now active transport, here is the only place where the ATP is required. Please remember, in facilitated diffusion no ATP is required. Okay, now it is against the concentration gradient. Whatever we have studied, it was towards along the concentration gradient, but this is against the concentration gradient, and a channel sodium potassium ATPase, alpha methyl dopa and levodopa, they all pass through the active transport. Okay, so alpha methyl dopa is important, levodopa is important. Okay, levodopa in Parkinsonism, right? Now pinocytosis is the cell drinking habit. Okay, basically the proteins are ingested in this way in the cell. Okay, now there is something important called pre-glycoprotein. Now pre-glycoprotein is nothing but MDR1, multi-drug resistant. It is a transporter. Okay, so MDR1, it is very important because you will learn in pathology also. There is a mutation of MDR1 and MDR2 that leads to many problems. Okay, many cancers also, and also drug will be if it is like more actively, so the drug will not act, because whatever the drugs we are taking in, the structure MDR1 will throw it out. Okay, जो खाएंगे उसको बाहर फेंक देगा. ठीक है, so basically it is an efflux transporter. And this is a way of causing resistance in organisms. The organisms has a way of causing resistance by using this kind of receptor, this kind of transporter. So what will do, whatever drugs will give act on the bacteria, it will throw out. ठीक है, जो देंगे वो फेंक देगा. ठीक है, it is an efflux transporter. Now P glycoprotein has some inhibitors and substrate as well as some inducers. Okay, so most important thing is the substrate is digoxin. Most important substrate is the digoxin. Okay, digoxin, very very important, and some other CYP substrates. It is very important MCQ and viva question, that what is the substrate for P glycoprotein? That is the digoxin. In P glycoprotein inhibitors, if we will say, it will actually cause the toxicity. It will increase the toxicity, and these are the drugs which are causing the toxicity of other compounds. Like it increases the toxicities. These are the P glycoprotein inhibitors. P glycoprotein inhibitors, what they will do? They will inhibit the P glycoprotein, so that the drugs which are inside the cells are unable to come out. So it will cause toxicity, right? So what are the drugs? These are verapamil, amiodarone, quinidine, clarithromycin, itraconazole, ketoconazole, nifedipine, erythromycin. See, the names of the drugs are very hard to remember because they are different classes of drugs, right? So you can make some mnemonic on your own, okay, or just just go through the mnemonics which I give, or all right. So at the end of the day, don't just remember the mnemonic and forget the drugs. So I'll repeat, these are causing drugs which are causing toxicity of different drugs because of the inhibition of the P glycoprotein, and these are verapamil, amiodarone, iodine containing drug, quinidine in malaria, right, clarithromycin, itraconazole, antifungal. Ketoconazole is a better drug, better P glycoprotein inhibitor than the itraconazole, right? Now nifedipine and erythromycin. So we'll study this in very detail in chemotherapy, and let's study about the P glycoprotein inducers. So what are P glycoprotein inducer? These are the drugs will be acting on the P glycoprotein, and it will stimulate the transporter to efflux out the drug. So whatever drugs we are giving to treat the patient, it will be throwing out very fastly. Okay? So what will do? It increases the activity and it decreases the effect of the substrate. It decreases the effect of the substrate, and these are GPRS. These are GPRS: griseofulvin, antifungal; phenytoin, antiepileptic; rifampicin, right, anti-TB and leprosy; and smoking. This smoking is very important. Like smoking is a P glycoprotein inducer. So what will smoking do? It will actually flush out all the drugs which are going through the P glycoprotein. So it is a P glycoprotein inducer. So smoking is a very important example, and this is a potent MCQ also and a viva question. That smoking P glycoprotein के साथ क्या करेगा? It will be actually increasing the activity of the P glycoprotein. It will increase the activity. Now the second thing is very important, is the route of administration. Now the route of administration, if we can see, is the local route and systemic route. In the systemic route there are the veins, and in the local route it's very important that it does not come into systemic circulation or veins, right? In systemic circulation, in topical, deeper tissues and intra-arterial. In the local route there is topical, is surface, okay, so skin, mucous membrane. In deeper tissues like intra-articular and intra-arterial, आर्टरी के अंदर में दिया जाता है in the local route. ठीक है. Systemic route में क्या हो गया? Enteral and parenteral. ठीक है. In the enteral there is oral, sublingual, enteral, right, and in the parenteral is the injectable and non-injectable. In the non-injectable, it is very important transdermal and inhalational, because these are non-injectable parenteral. ओके, क्योंकि पैरेंटरल बोलने से सब लोग आईवी समझता है, नहीं, पैरेंटरल में इंजेक्टेबल होता है जिसमें आईवी, इंट्राडर्मल, इंट्रामस्कुलर, सबक्यूटेनियस होता है, ठीक है. बट ट्रांसडर्मल इज अ नॉन इंजेक्टेबल फॉर्मुलेशन एंड इट इज़ अ पोटेंट MCQ as well as your viva question. Okay, inhalational is also non-injectable parenteral formulation. Sublingual, enteral and oral are the enteral routes of systemic circulation, systemic route of administration. Okay, clear? Now this oral they have barriers. So what are the barriers? Mucosal and cellular barrier. In the liver there is first pass metabolism. This is a very important question. What is first pass metabolism? Okay, what is the first pass effect? Right? Now there is something called mucosal barrier. So first pass effect occurs in the liver. Only liver is false, because first pass metabolism occurs in the intestine. First pass metabolism occurs in the liver. Okay, and there are places where the enzymes are present. There are actually the drugs are metabolized in some part, in some way, right? Now 100% hydrophilic drugs. Mucosal barrier, this is very important, because there comes the passive diffusion, which is the most common method, and lipid soluble drugs, non-ionic drugs get the via this oral whatever oral administration we are giving, so they get absorbed. Okay, now 100% hydrophilic, the strong ionic drugs, right? So what happens, like ionic, there is a strong acid or strong base, they do not cross, but 100% hydrophilic drugs cross. Okay, examples are the insulin, tubercular and streptomycin. This is the SID drugs: streptomycin, insulin and tubercular. Okay, so these are the drugs which are 100% hydrophilic. Now the most drugs are the weak ionic drugs. Weak ionic drugs are weak acid or weak base. Now it is important that the pK of the drug is a very important thing to note, because like this will actually show how much the drugs is soluble in water and absorbed properly, right? Now lipid solubility test has been done while making a drug. While we are in the drug development process, there were many tests which are done for the drug, so that the absorption quality and the absorption, the ionicity of the drug are tested. Okay, now the pK of the drug is the lipid solubility of the drug. So suppose a drug is there and it is 50% lipid soluble and 50% water soluble, then the pH is equal to pKa. Now pH is to pKa, it is very important. This is a potent MCQ, that pH, the drug is 50% ionized and 50% non-ionized. So जो आयोनाइज रहेगा वो वाटर सोल्यूबल होगा, जो नॉन आयोनाइज होगा वो लिपिड सोल्यूबल होगा. ठीक है. नाउ दिस इज वेरी easy, and to understand this Henderson-Hasselbalch equation, we have studied this equation. This is the formula: pK is equal to pH log non-ionic concentration by ionic concentration. Non-ionic concentration by ionic concentration. Now the important to understand is aspirin is acetyl salicylic acid, so it is an acidic drug, and morphine is a basic drug. Okay, so it is an acidic drug, so इसका pKa बोला जाएगा, that is 3.5, और this is basic drug, इसका pKb बोला जाएगा, it is 8.5. So this we have to understand that water solubility is between this acidic drug and basic drug. These are weak ionized, so these are water soluble, but extremes are lipid soluble. Extremes are the lipid soluble. It means more than strong as basic या strong acidic बोला जाए, तो these are lipid soluble. This you have to understand, right? Now this aspirin in 0 to 1%, like the HCl is secreted, right? So there is something called ion trapping of the aspirin in the treatment of the peptic ulcer. So aspirin, that is in the cause of the peptic ulcer. Okay, so there is ion trapping of aspirin which is causing the peptic ulcer. Now the basic drug is more absorbed in the small intestine, the maximum in the duodenum than the stomach. Duodenum than the stomach. Now acidic drug is more in the small intestine due to greater surface area and then the stomach. So again, both basic and acidic drug are absorbed in small intestine more than stomach. Very important question. Now stomach is acidic drug, higher proportion is absorbed stomach, because the medium is the acidic medium, right? Now what happens next is the first pass metabolism. In the first pass metabolism, we calculate the hepatic clearance, that is Ca minus Cv by Ca into hepatic blood flow, and this is the extraction ratio. So this is one of the calculation that find the hepatic clearance when the hepatic blood flow is this and extraction ratio is this. Okay, इस तरह से. So if the extraction ratio is 10 and hepatic blood flow is 10, so the hepatic clearance is 100, something like that. High first pass metabolism in liver. So which are the drugs which are not given orally? These are hilltop, which are not given orally. Hydrocortisone, isoprenaline, lignocaine, testosterone, estrogen and progesterone. You can see these are hormones, right? These hormones are not given orally because they will be degraded. Hydrocortisone is also an steroid, it is not given orally. Isoprenaline and lignocaine names you have to remember, otherwise all the steroids. Hilltop. Okay, these are high first pass metabolism in liver, so they are not given orally, they are injectable drugs. High oral use, which are the drugs which are given orally? Okay, so these are propranolol, morphine, wait a minute, pethidine, imipramine, nitrates and bisphosphonates. Now these are the drugs. These are drugs which are they are not given orally because of high first pass metabolism. But what happens, like these drugs are given via different route apart from oral, because this will be highly metabolized in the will be highly first pass metabolism will be there. Okay, so they will be given sublingually, okay, like, and they will be given via inhalational routes. Okay, so these are the things you have to understand. These are many given intra-articularly. Now, to avoid the bypass or the first part metabolism of liver, drugs are given with the other routes, except the oral, they are given by the other routes. Now the sublingual or the rectal. Now the sublingual, the tongue, they have sublingual veins which drain into superior vena cava and directly into the heart. So the example is the nitroglycerin. It is an acute attack of angina, nitroglycerin is used. In the rectal, there are rectal external hemorrhoidal veins. In the external hemorrhoidal vein which drain into the inferior vena cava, and it will be drain into the inferior vena cava, and it will go to the heart for the circulation. Rectal diazepam is given in febrile seizures. It is very important. Okay. Now this is the external hemorrhoidal vein जो drain करता है IVC में, but the internal hemorrhoidal vein will be draining into the portal vein and it goes to the liver, and the first pass metabolism will be there. So it is an important question. Other routes is important. Other routes में क्या आ जाएगा आपका, पेरेंटरल में IV आ जाएगा. इट इज़ 100% बायोअवेलेबिलिटी, ये हम लोग मानते हैं. डोज टाइट्रेशन इज़ पॉसिबल, यस. सो 100% वो वेन में जा रहा है. IV और जो इनहेलेशनल इज़ इवन बेटर. इनहेलेशन में जनरल एनेस्थीसिया दिया जाता है और उसमें भी डोज टाइट्रेशन होता है, इट इज़ पॉसिबल. सो IV एंड इनहेलेशनल बोथ हैव dose titration effect. Now transdermal route, dose is the area of the patch. जो पैच लगा रहता है स्किन के साथ में, और ये ब्लड वेसल्स हो गया तो कितना अंदर जाएगा, इट डिपेंड ऑन द एरिया ऑफ द पैच एंड द लिपिड solubility of the drug. Now the site is like maximum absorption is there in the post auricular area over the mastoid process, then the scrotum, then the face and neck. Minimum absorption is the palm and soles. Minimum absorption is the palm and soles. What are the drugs which are given via this route, that is the transdermal route, is the drugs and their uses. Like nicotine is used for the smoking cessation. Long acting nitrates are given in chronic angina. Okay. Naltrexone is given for opioid de-addiction. Fentanyl is given as an analgesic. Rivastigmine is given in Alzheimer's. Rotigotine is given in Parkinsonism. Clonidine is given in hypertension, right? Alpha 2 agonist. Scopolamine, hyoscine and diphenhydramine is given in motion sickness. Selegiline is given in depression. Estrogen, depression in the Parkinsonism. Estrogen and testosterone are given as an HRT. Okay? This you have to understand. Hormone replacement therapy. Now, these are the drugs which are given transdermally. These are the drugs which are given transdermally. Now, another concept is the bioavailability. That we are going to study in the absorption part. It is a fraction of drugs that reaches the systemic circulation with time in unchanged form. This unchanged form term is important, and bioavailability, the fraction of the drug, the term is important, right? Fraction of the drug comes in unchanged form that reaches the systemic circulation with time is the bioavailability. IV as highest, considered as highest bioavailability, and other routes are, because of this barrier, they are less than 100%. Okay, so why this? We calculate the plasma concentration time graph. So plasma concentration and time graph, this is the area under the curve, and this is the bioavailability. The bioavailability is being given by the symbol F. Okay, it has no units because area under the curve divided by area under the curve of concentration time graph of oral by concentration graph by IV, that is considered as 100%. That is the bioavailability. ठीक है. Now calculate the area under the curve. तो वहाँ पे हम लोग क्या करते हैं, ट्रेपेजॉइडल रूल लगाते हैं. ट्रेपेजॉइडल, we divide into the trapezium and then we calculate. We divide in trapezium and then we calculate. यहाँ तीन टर्म्स है, C max, T max and area under the curve. तो T max मतलब C max क्या है, दैट इज द मैक्सिमम कंसंट्रेशन और वो सेफ्टी शो करता है. और T max दैट इज स्पीड और वो रेट ऑफ एब्जॉर्प्शन पे डिपेंड नहीं करता है. वो T max वो टाइम है जब कंसंट्रेशन मैक्सिमम होता है. एंड टोटल एक्सटेंस ऑफ एब्जॉर्प्शन वो चीज़ एरिया अंडर द कर्व में पता चलता है. ठीक है. देयर इज अ सिमिलर टर्म इज नोन एज द बायो इक्विवेलेंस. इज द कंपेयर द बायो अवेलेबिलिटी ऑफ टू ब्रांड्स ऑफ द सेम ड्रग, ऑफ द जेनेरिक ड्रग्स, राइट. तो टू ब्रांड्स को हम लोग क्या कर रहे हैं, कंपेयर कर रहे हैं. So acceptable limit is the 80 to 125%, that is the plus minus 25%, plus minus 25%, except for the phenytoin, that is eptoin or dilantine. We never change the brands of phenytoin because all brands of phenytoin are bio-inequivalent. ठीक है, all brands of phenytoin are bio-inequivalent. इसका मतलब क्या हो गया कि if a patient is taking eptoin, ठीक है, and you come the patient came to you and you came to know that the patient pharmacist is trying to give dilantine instead of eptoin, we directly say no, because if a change of brand will be there, a bio availability will be different, then the patient might have an attack of seizure because of change in the bioavailability of the phenytoin. Okay, so in the phenytoin only we are not changing the brands. Okay, now distribution. In the distribution is very important. The drugs will be acting on the organs to causing the effect. So drug will be acting on the target organ and it causes the effect, but the drug will be acting on the other organs and causing the side effect. So the side effect is when the drug will act on the other organ instead of the target organ. So that is it is important. And here we calculate the apparent volume of distribution. Okay, so this is the apparent volume of distribution. This is extravascular deposition of drug in organ. Extravascular deposition of drug in organ. It is the false or the apparent volume. It is false or the apparent volume. Definition is volume of plasma needed to contain a drug in equal concentration. Volume of plasma needed to contain a drug in equal concentration. It is a very simple definition. How we calculate it? The dose given IV by plasma concentration. So the volume of distribution, the unit is in the liters. But we express volume of distribution as liters per kg of body weight. We express volume of distribution as liters per kg of body weight. Now, volume of distribution depends on the lipid solubility and the plasma protein binding. Depends on the lipid solubility and plasma protein binding. That is the lipid solubility. It is directly proportional कि जितना ज़्यादा lipid soluble होगा volume of distribution उतना ज़्यादा होगा, और plasma protein binding अगर ज़्यादा होगा तो volume of distribution कम होगा. ठीक है. So these are very important things to understand. Other factors are age, gender and pregnancy. Pregnancy में और age के according male female में भी थोड़ा सा difference होता है. And some diseases like nephrotic syndrome, CKD, cirrhosis, CHF and hemorrhage, इसमें वॉल्यूम ऑफ डिस्ट्रीब्यूशन चेंज हो जाता है. ठीक है. तो उतना डिटेल में आपको नहीं जानना है, बट द बेसिक थिंग यू हैव टू अंडरस्टैंड इन डिजीज, इन प्रेगनेंसी स्टेट एंड जेंडर एंड एज अगर डिफरेंट होगा और लिपिड सोलिबिलिटी और प्लाज्मा प्रोटीन बाइंडिंग, इन सब पे वॉल्यूम ऑफ डिस्ट्रीब्यूशन डिपेंड करता है. नाउ द प्लाज्मा प्रोटीन इज इंपॉर्टेंट कंसेप्ट कि इट विल बाइंड इन द एल्बुमिन एंड एल्बुमिन विल is a basic plasma protein, and acidic drug will bind in the basic plasma protein. Now alpha 1 acid glycoprotein, now please note P glycoprotein is different from alpha 1 acid glycoprotein. ठीक है. P glycoprotein अलग चीज़ था. ठीक है. वो MDR ट्रांसपोर्टर था. alpha 1 acidic glycoprotein is an acidic plasma protein where the basic drug will go and act. ठीक है. तो एसिडिक ड्रग का नाम कुछ बताइए अगर क्वेश्चन आता है आपका, तो एस्पिरिन, बार्बिचुरेट्स, बेंजोडाइजेपिन्स, एनसेड्स. और अगर बेसिक ड्रग का नाम पूछा जाए तो एंटी एरिथमिक्स लाइक एम्यूडोरॉन, क्विनिडीन, बीटा ब्लॉकर्स लाइक प्रोपेनोलॉल, कैल्शियम चैनल ब्लॉकर्स लाइक वेरापामिल, डिल्टियाजेम, ओपियोइड्स लाइक मिथाडोन, मॉर्फिन, इमिप्रामिन, लोकल एसिडिक लाइक लिग्नोकेन, बुपिवेकेन. दीज आर द बेसिक ड्रग्स. ठीक है. एसिडिक ड्रग्स में क्या आ गया? एस्पिरिन, बार्बिचुरेट्स, बेंजोडाइजेपिन्स, एनसेड्स, एंटीएपिलेप्टिक ड्रग्स लाइक फेनेटोइन, कार्बामाजेपिन, वैल्प्रोएट, एंटीमाइक्रोबियल्स लाइक सल्फोनामाइड्स, टेट्रासाइक्लिन, पेनिसिलिन, वारफेरिन, टॉलब्यूटामाइड्स. नाउ other things like sex steroids like estrogen and progesterone and testosterone, they binds to albumin and it binds to sex hormone binding globulin. This is an important concept. This binds to albumin as well as they binds to sex hormone binding globulin. The plasma protein is non-specific. Multiple drug can bind to the same site. Okay, so there will be displacement. So suppose phenytoin and phenobarbital, if given together, so what will happen? That they both are anti-epileptic drug and they will increase each other toxicity. So they will have a side effect of phenytoin toxicity as well as phenobarbital toxicity. Okay? So this is important. Sulfonamide, it is absolutely contraindicated in neonates because it displaces the bilirubin from the albumin. So sulfonamide displaces the bilirubin from the albumin. Okay? So this will cause the Kernick terrace in the it will cause the neuronal damage in the blood in the neonates because the bilirubin will be free and it will cross the blood-brain barrier and it will deposit called the Kernick terrace. Now, what is the clinical importance of volume of distribution? So, what is the clinical importance of volume of distribution? So, the process of hemolysis, and in a case of poisoning of drugs, we use the concept of volume of distribution. Now, if there is a high volume of distribution drug, there is no role of hemodialysis. If there is low volume of distribution of drug and high plasma protein binding, there is no role of hemodialysis. So when to do hemodialysis? Hemodialysis कब करना चाहिए? Low volume of distribution in blood and free or soluble in plasma and low plasma protein binding. These drugs are having hemodialysis. So when we have to do hemodialysis? In case of barbiturate poisoning, lithium, it is a very important drug which is used in the maniac bipolar disorders, right? So if there is lithium का poisoning होगा वहाँ पे हम लोग hemodialysis करेंगे. अल्कोहल पॉइजनिंग, इथाइलिन ग्लाइकॉल या फिर अगर मिथेनॉल दिया जा रहा है वहाँ पे हम लोग हीमोडायलिसिस करेंगे। एस्पिरिन, सैलिसाइलेट्स, थियोफाइलिन, इन सब में हम लोग हीमोडायलिसिस करेंगे। बट वेयर देर इज़ नो रोल ऑफ हीमोडायलिसिस, these are amphetamine poisoning, verapamil poisoning, opioids, warfarin poisoning, organophosphorate carbamates, imipramine, digoxin, very important, diazepam, chloroquine, right, amiodarone, their cases there are no role of hemodialysis। अगर इनका पॉइजनिंग होता है आप हीमोडायलिसिस नहीं कर सकते हैं, इनका पॉइजनिंग होता है तो आप हीमोडायलिसिस कर सकते हैं। ठीक है, दिस इज इम्पॉर्टेंट। नाउ digoxin has a volume of distribution of 450 liters of plasma and chloroquine has the highest volume of distribution, that is more than 15,000 liter of plasma। ठीक है, 15, हाँ, तो इससे क्या हो जाएगा, इससे होगा कि देर विल बी रेटिनल डैमेज एंड डिपोजिशन एंड मैक्यूला में तो देर इज़ अ रिंग डिपॉजिट जो इसमें दिखता है, इसको बोलते हैं बुल्स आई रेटिनोपैथी कॉज बाय द क्लोरोक्विन बिकॉज ऑफ द हाई वॉल्यूम ऑफ डिस्ट्रीब्यूशन। So we have done absorption and distribution. Now we will go for the metabolism of the